This episode is based on Anxiety-Related Dizziness, a Vestibular Physician's Deep review of panic disorder, generalized anxiety, and hyperventilation syndrome, published by Australian Dizziness Clinics. Okay, let's dive into this. Welcome to part 4 of our explainer series on anxiety-related dizziness. For us, as vestibular physicians, neuro-otologists, and advanced practitioners, well, this is exactly where the rubber meets the road. Today, our absolute core goal is mastering the diagnostic funnel. We're going to look at exactly how to make a confident, positive call for anxiety-related dizziness, all while systematically screening out those dangerous mimics that, love to hide behind very similar presentations. It's really not just about ruling things out anymore. It's about confidently ruling something in. So here's our game plan for today. We'll start with the positive paradigm, move into psychometric screening tools, go through the vestibular workup, cover the red flags to exclude, and finally, synthesizing the diagnosis. It's a logical flow, really, moving from the broad presentation straight down through objective screening, testing, those non-negotiable red flags, right down to our final synthesis. Section 1. The positive paradigm. We really need to dispel an outdated but still surprisingly common myth in vestibular medicine. For decades, diagnosing anxiety-related dizziness was kind of treated as this fallback, a diagnosis of exclusion that we only arrived at when literally every other test came back totally clear. But that's simply not true anymore. It is a positive clinical diagnosis based on meeting DSM-5 anxiety criteria, plus a consistent vestibular history and examination. So diagnosing this well means we are actively confirming functional or sensitized processing. We're not just shrugging our shoulders when tests come back normal. We're actively looking for specific criteria combining with specific history. Now, what's really interesting about this slide is how it maps out the diagnostic assessment pathway. Taking a full, detailed history is exactly what separates primary anxiety from secondary, post-vestibular anxiety. You're parsing out the trigger profile, the sleep patterns, the whole shebang. Then you do your vestibular examination. Hints, Dix-Hallpike, VHIT. If you spot a structural lesion or a neurological sign, you branch off immediately. But if you don't, you proceed to vestibular function tests, and finally, check if they meet those DSM-5 criteria. It's a highly structured, logical flow that guides us right to the answer. Section 2. Psychometric screening tools. Let's be real, in a busy clinic setting, having objective psychometric tools administered before the patient even walks into the room is an absolute lifesaver. It quantifies the patient's burden without eating into your consultation time. So here are the 3 heavy hitters. First up, the HATS, the Hospital Anxiety and Depression Scale. Scores of 11 or more suggest a definite case. Next is the DHI or Dizziness Handicap Inventory. For this one, we're keeping a sharp eye out for elevated emotional subscores. And finally, the Nijmegen questionnaire. Targeting hyperventilation, I really want to emphasize this actionable threshold right here. A score of 23 or more actively supports hyperventilation syndrome, or HVS. That number is a crucial clue. Section 3. The vestibular workup. When we run vestibular function tests, or VFTs, in patients where we suspect anxiety-related dizziness, we're basically hunting for nuanced somatopsychic clues. We're using tools like VHIT, calorics, VEMPs, and posturography. But listen, we really have to reframe how we view these tests. They aren't just for ruling structural issues out. Actually, they actively help us find the subclinical peripheral dysfunction that might be acting as the trigger for that patient's vicious anxiety loop. Comparing the test findings reveals a pretty stark contrast. In anxiety-related dizziness, the video head impulse test, the VHIT, typically shows a normal VOR gain bilaterally, with no catch-up saccades. Caloric testing might be completely normal, or maybe it just shows a mild directional preponderance tied to sympathetic tone. But contrast that with a structural unilateral vestibulopathy. There, you're going to see reduced VOR gain, overt saccades, and a severe canal paresis of over 25% on the ipsilateral side. So seeing those normal or near-normal results right alongside a high anxiety score, that is highly diagnostic in its own right. But what happens when the test shows something a bit unusual, but not structurally damaged? Well, in these patients, VEMPs are typically normal, but sometimes you'll actually observe heightened VEMP amplitudes. This is a direct reflection of vestibular sensitization. On top of that, on computerized dynamic posturography, anxious patients classically show an aphysiological pattern, meaning they actually perform worse with their eyes closed on a stable surface than they do on conditions that are genuinely way more challenging for a true structural vestibular lesion. We've got to frame these heightened or aphysiological results not as, oh, nothing is wrong, but as active, positive support for a central, sensitized mechanism. Section 4. Red flags to exclude. Up to this point, we've looked at what confirms our diagnosis. But listen closely. These are the strict, non-negotiable clinical boundaries we absolutely must respect. Anxiety frequently coexists with organic pathology and can mask it completely. If a patient presents with new or progressive unilateral hearing loss, which could be Meniere's or a vestibular schwannoma, image first. If you see focal neurology like cranial neuropathy, ataxia, or diplopia, image first. Prominent spontaneous or direction-changing nystagmus, that's central vestibular pathology until proven otherwise, so image first. What about acute severe vertigo at rest? Could be an ACA or PICA infarction, image first. And if there's an orthostatic component or onset after head or neck trauma, you have to investigate to exclude autonomic failure, a paralimb fistula, or BPPV. These red flags absolutely mandate an MRI or further structural investigation before an anxiety diagnosis is even considered safe. No exceptions. Section 5. Synthesizing the diagnosis. This right here is the core takeaway mantra of Janae's explainer, the positive diagnosis composite. By ensuring the patient meets these strict DSM-5 criteria and pairing that with vestibular examination findings that are totally consistent with functional or sensitized processing, we confirm anxiety-related dizziness. We are merging the psychological evidence from our history and screening tools right together with the physiological evidence from our VFTs. When you have normal structural testing combined with elevated anxiety scores, you don't have a mystery on your hands. You have a rock-solid, positive composite diagnosis.
Join me in Audio 5, Pharmacotherapy and Stepped Care, where we build the drug plan and the wider management framework. For additional resources, including the full literature review, clinical cheat sheet, and patient leaflet, visit AustralianDizzinessClinics.com. Please subscribe to support the channel. I want to leave you with this final provocative thought. When we finally stop treating anxiety-related dizziness as a frustrating diagnosis of exclusion and start treating it as a positive, identifiable mechanism, just think about how much more confidence and clarity you're going to bring to your clinical practice tomorrow.